Hello, everybody, and welcome to Chapter 8, our first chapter for Unit 3. So, we're going to talk about joints and movement before we get into the muscles for the rest of our chapter, or the rest of our unit, I should say. Okay, so we're going to talk about two different classifications or way that we can break down our types of joints. So, these have a little bit of overlap, but they're really two separate ways to break these down. So, we're going to go through both of these classifications. The first one is structural, and it's based on our type of connective tissue that forms or binds these bones, forms these joints. The other classification we have is functional, and that's based off how they function in a sense. So we have our synarthrosis is going to be non-movable, our amphiarthrosis is going to be slightly movable, and our diarthrosis is going to be freely movable. Now, we can't quite put these same definitions with these three categories, but it does flow in a similar way in the fact that our fibrous joints are going to be our least movable, our cartilaginous joints are going to have slight movement, and then our synovial joints are really going to be our joints that have the most freedom for movement. So now we're going to kind of start subdividing these categories. So our fibrous joints are going to be connected by fibrous connective tissue. We said that's how we name this classification. There's no joint cavity present, and there's very little or no movement. So these three subcategories all are considered fibrous joints. Sutures is something that we looked at already in the skeletal system. So sutures are these lines that form via intramembranous ossification. And so we had four main ones that we looked at on the skull, and these are going to be completely unmovable. They lock in just like a puzzle piece. In an infant skull, these sutures are going to be fontanelles. So that means they're not fully ossified yet, which still allows growth of the brain and change of our head shape and size. And then once we reach kind of our full head size, full brain size, we can go ahead and ossify those sutures fully. Excuse me. So here's just another kind of look at what an infant skull would look like. It's going to have those membranes, those fibrous membranes, rather than those full sutures at that point. The next type of fibrous joint is a syndesmosis. And so this time they're going to usually connect two bones that are next to each other. And so an example of this would be the radius and the ulna. Another example of this would be between the tibia and the fibula. So they're not necessarily making a joint like we think, say, our elbow, our ulna fitting into the humerus. Um, but they are forming a joint in the fact that these are still connected with this sheet of fibrous tissue, which is known as the interosseous membrane. So in between the bones, interosseous. And there's going to be some movement. So think of our radio-ulnar joint. When we pronate and supinate, our radius is still able to roll over the ulna. So it doesn't completely stop them from moving with or interacting with one another, but there's not going to be a lot of movement between these. The next one is a special type of joint, and a gomphosis, you can think of a peg that fits into the socket. By far, our best example of this is our teeth. So our teeth are set into alveolar bone with periodontal ligaments. Remember, bone to bone is a ligament. And so this is our peg fitting in the socket here. Here's just a couple of kind of highlights of pathology that can relate to our teeth specifically. So gingivitis is when the gums themselves get irritated or infected, and that can spread down into the socket. And chronic gingivitis or severe gingivitis can lead to periodontal disease, which can affect uh, actual loss of the tooth. Our next category is cartilaginous joints, which are, of course, going to be united by cartilage. So we have two that fall under this category. We have synchondroses, and then we have symphyses. So we've talked about both of these, even if we haven't quite named them like this yet. So synchondroses are going to be hyaline cartilage, and there's going to be little or no movement. So we'll see hyaline cartilage in a couple of our other joints, but in this case, it's really not providing any surface for movement. Something like an epiphyseal plate, we consider a synchondrosis. And we said back in our skeletal chapter that we only find epiphyseal plates in bones that are still growing. So when our epiphyseal plate is replaced with an epiphyseal line, we then refer to it as a synostosis. So I always think it stopped growing. So now it's a synostosis instead of a synchondrosis. Not always do they go from a synchondrosis to synostosis. The best example of that is our epiphyseal plate to epiphyseal line. Some will remain synchondrosis. A great example of that is our sternal cartilage, as well as the costal cartilage, where our ribs connect to the sternum. On your bone markings list, we had the pubic symphysis, and really that was kind of a space in between both halves of our os coxae, our coxal bones, the pelvis. So this line right here is our pubic symphysis. It's slightly movable. It's going to be fibrocartilage, so this is going to be the tougher form of cartilage. Another example of this would be our intervertebral discs of the spine. So those discs are also made of fibrocartilage, and we can consider those symphysis joints as well. So what we're going to focus on a little bit more later on in this chapter is our synovial joints. And so one kind of common characteristic of synovial joints is that they all contain synovial fluid. They also have to have a joint capsule or a joint cavity because that's where that synovial fluid is maintained. And this is going to allow a lot more movement than the other categories we have talked about. And because of that, they have a bit more of a complex structure. So we're going to look at this two different ways. So we have a whole bunch of words here that describe our synovial joint, and then we'll look at the image itself and we'll talk through some of these same pieces. So just like any long bone or any joint, we're going to have articular cartilage at the ends of our bone. Remember, those are the epiphyses, and so that's hyaline cartilage. So articular cartilage and hyaline cartilage are synonymous, and that's really just providing a smooth surface, preventing friction, giving us something to slide across. Our joint cavity itself is considered the synovial cavity, and it's going to enclose that articular surface completely. Our joint capsule actually has two parts. We have kind of the protective fibrous capsule. This is going to kind of merge right in with our periosteum. And this is also what is going to kind of form our ligament or merge into the ligament. On the inner portion, the deeper portion of our capsule, we have our synovial membrane, which is going to produce synovial fluid. So synovial fluid is a mixture of a lot of different things. And all of those combinations, one, provide the joint with some nutrients, two, and most importantly, it really makes our joint slippery. Our synovial fluid is like the oil in the car, WD-40. That along with this articular or hyaline cartilage is what prevents friction when our bones are moving. Cartilage is really poorly supplied with blood and nerves. So things around our cartilage can certainly hurt, but cartilage itself doesn't typically have much innervation, much of a nerve supply. The blood vessel side of things is really the important part, or why we bring this up, because remember, blood's our transport mechanism for pretty much everything in the body. So if we don't have a good blood supply somewhere and there's an injury there, it's much harder for that to heal if we're not getting as many nutrients there. So in this case, we're really relying somewhat on our synovial fluid itself to get nutrients to the parts of our cartilage that don't receive those from a good blood supply. One other special, and I shouldn't say special because we have these all over in all our joints, nerves that we have within our joints are responsible for a sense known as proprioception. And so proprioception is knowing the position of our joints in space. So the example that I like to use is if you close your eyes and you raise your right hand, you can raise your left hand to about the exact same spot, even though you're not looking, because of proprioception. So that's what's going to tell our brains where our joints are in space. All right, now if we go ahead and take a look at this in image form. So this is the ends of our long bones. So we have hyaline or articular cartilage on the ends here. This is showing a tendon. So in this case, this would be for a muscle. This is showing our periosteum. So that's the covering of our long bone. And then we have our actual joint capsule. So this outer portion is the fibrous capsule. That's our protective portion. And you can see it runs right into that periosteum. The synovial membrane is this deeper inner portion. It's going to produce the synovial fluid. One other thing that I want to point out here is this bursa. In this case, our bursa is just an extension of the joint cavity. And the way I like to think of a bursa is like a Tide Pod. So think of a Tide Pod or a dish detergent pod that kind of has fluid filled with it, but it still has a little bit of squish and give to it. And so that's the job of a bursa is to provide some cushioning or padding. So it's going to be a fold or a pocket of the joint cavity. Sometimes we can have a multiple bursa around a joint, and we're really going to find it in spots where we would get additional friction. So if there's two spots that are going to rub, if there's a tendon traveling right over the area, if there's a bony prominence sticking out or a lump sticking out, we may find a bursa. If it's close to the surface, we may find a bursa. So remember, a bursa is just there to add a little bit of extra cushioning and protection. And that is what I said right here. Bursa can get inflamed. And so bursitis is a very common diagnosis that we deal with, especially in the hip and shoulder. Ligaments and tendons, just remember which goes with which. So ligaments are bone to bone, tendons are muscle to bone. One other thing that I always like to point out is kind of a nice to know is that we sprain a ligament or a joint with a P. We sprain it. If we hurt a tendon or a muscle, if you pull a hammy while you're running, you strain that muscle or you strain a tendon. Sometimes we have articular discs of cartilage. So a good example of this would be our temporomandibular joint, your TMJ, which is your jaw. So if you put your fingers, kind of two fingers right in front of your ears and open and close your jaw, you will feel that TMJ moving. And so the TMJ between your mandible and your temporal bone has a disc that allows those bones to open and close without rubbing the two ends. And so if you ever get a pop when you're opening your mouth, sometimes that's that disc popping in and out of place. Menisci are kind of rings of cartilage. We mostly talk about this in the knee. And so we have a medial and lateral meniscus in both of our knees, and it helps our knee be a little bit more congruent. It helps our knee stay more stable, and it's also a good shock absorber. And that's going to be, again, fibrocartilage. And then tendon sheath. So we said a tendon connects muscle to bone, but the tendon itself is going to be contained within its own covering or sheath that is a synovial membrane. And so it surrounds the tendon, it provides some nutrients, and it also does lubricate it as well. We don't necessarily rub against the bone or have cartilage in there, but we do have synovial fluid so that tendon can move in the sheath as our muscle is shortening and lengthening. All right, our synovial joints are the most allow the most movement, and so we have some different shapes to these. Not all of our joints move exactly the same, and that's because they have different shapes. So one of the words that you'll see with each shape is uniaxial, biaxial, or multi-axial. And so that really just tells us how many different axes this joint can move around. I don't necessarily need you to memorize the which ones go with which. Just understand that A biaxial joint is likely going to move a little more than a uniaxial joint. And our multiaxial, we'll see one or two examples of this that can move a lot of different directions. All right, our first two are plane and saddle joints. So plane joints are uniaxial. There's a little bit of rotation that can happen on the flat surfaces, but they really just slide across each other. There's not much movement besides sliding. I would say take a look at our bolded examples. We don't expect you to certainly memorize every single one in this list, but having at least one of those bolded examples in your brain will help you remember how that joint looks. A saddle joint we really only find in the thumb, not only, but that's our best example of this. And this is going to be biaxial. So if I look at my shape here, I kind of have a saddle facing a flipped over saddle. And so that allows a little bit more movement. So that's biaxial. And again, all of these fall under the synovial joint category. Hinge joints, best example of this would be our elbow. And so they're going to be very stable. Typically, we're going to have a convex part of our bone fitting into a concave socket. And so it's uniaxial. It's only gonna our elbows only flex and extend, but they're very stable joints because we have a nice pocket for it to fit in. Pivot joints do exactly what they sound like. They pivot, they rotate. So our proximal radial ulnar joint, so when we pronate and supinate, that's a pivot. Our dens, that comes off of our axis when it's interacting with the atlas, we have a pivot on the dens. So pivot joints do exactly what they sound like. It's rotational. So uniaxial for both of these guys. Our ball and socket is really the one that we talk about the most with our synovial joints in terms of movement. So this is our multi-axial example, our shoulder and our hip. And so this is going to allow the most movement in the body. And so we always say within the body, we have a relationship, we can call it, or a trade-off between mobility and stability. So if something is really mobile, it's going to have a lot more instability. We need to control that motion. If something isn't very mobile, something like our elbow that's uniaxial and only goes back and forth, we're going to have a lot less instability issues. So it's pretty rare to see an elbow dislocation except for really young children. But in sports, we see shoulder dislocations or shoulder injuries that affect shoulder stability all the time because the shoulder can move in so many different ways compared to the elbow. Our last one is an ellipsoid, also known as a condyloid joint. And if you remember that it's also known as a condyloid, you can remember this example because it's where our occipital condyles are going to sit on those the pockets or the holds of our atlas. And so it's similar to a plane joint, but if you remember on the atlas, it had a little bit more of a concave surface and our occipital condyles were just slightly convex, so a little bit more movement than a plane joint. So these are considered biaxial because then we can nod up and down. We can also rotate, and we can also kind of go ear to shoulder as well with that joint. All right, types of movement. So for these, it's really the best thing to do is look at images, go to YouTube, go to Google, and actually watch body parts move. So we're going to kind of talk through this, and I want you to remember some of the definitions that go with these. But I think this is one that you really need to watch it happen to get a better picture in your mind. And keep in mind, depending on what joint we're talking about, these movements are going to look slightly different, even though they all fit with our definitions. So the first one is flexion and extension. So I'm going to pop forward for a second. So flexion is reducing the angle of a joint. Extension is increasing the angle of the joint. So when I bend my elbow in, I'm reducing this angle. When I straighten my elbow out, I'm increasing this angle. Same thing with my knee. When I go towards my butt, that's knee flexion, like a butt kicker. and my knee is going to decrease its angle. If I extend, if I straighten out, I'm going to have an increased angle. For some body parts like the neck, the low back, the wrist, even some people's elbows and knees, we can get extension beyond our normal anatomical position, what we consider full extension. So we can call that hyperextension. And sometimes, like the knees and elbows, we don't necessarily want much hyperextension. That's not necessarily a normal thing. But for stuff like the wrist and the neck, if we didn't have hyperextension, we'd be pretty limited in how well we can move. Dorsiflexion and plantar flexion are kind of a special type of flexion extension that only go with the ankle joint. And so the top part of our foot is the dorsum, the dorsal side of our foot. The bottom is the plantar side of the foot. And so plantar flexion is when we are pointing the toes. It's like a calf raise, a gas pedal motion. Dorsiflexion is the opposite. And so this is when the foot is going to lift towards our shin. Abduction and adduction sometimes are referred to as abduction and adduction, where we have either movement away from the midline or movement towards the midline. So I always use a jumping jack as an example. When you first spread your legs and arms go up to your up towards your head, that's abduction for both. We're going away from the midline. When we bring our arms back to our sides, when our feet come back together, that's considered adduction. So you can think of it as we're adding that body part back towards the body. Rotation, we can talk about in a couple different ways. So, right and left rotation is like you're turning your head to look over your right shoulder or your left shoulder. Medial and lateral rotation are a bit different. And so, when we talk about rotation, we're thinking of the long axis. Think of the vertical axis, that DENS. If we took that DENS structure through our spine and drew a full vertical line, that's what we're rotating on. So we usually talk about medial and lateral rotation with the shoulder. It's not the only body part. The hip can do this as well. So for medial rotation, if we have my hands at our sides, like our model here, if you rotate so that your elbows stay at your sides, but your pinkies go towards your belly button, that's medial or internal rotation. For lateral rotation, we start at the same position, but this time we're going to rotate out. Your shoulder blades will kind of pinch together, and then your elbows should stay at your side while your thumbs kind of point away from your body. So that would be lateral or external rotation. At the hip, if we turned our toes out, that's lateral rotation. If we point our toes in towards each other, that would be medial or internal rotation. Pronation and supination, we talked about way back in the beginning because of anatomical position. So with pronation, your palm faces posteriorly if hands are at the sides. It would face the ground if you have your elbow at a 90-degree angle. The way I always remember it is that my palms face up or anterior. If you make a bowl with your hands, that's supination. Please, can I have some soup? So that's how you can remember pronation versus supination. Keep this in mind that we also, especially in like a hospital setting, would talk about prone versus supine patient position. Prone meaning on the stomach, supine meaning laying on their back. When we're talking about the forearm itself, we talk about pronation and supination. And the forearm is really the only spot we talk about this. Um, we technically can have pronation and supination of the foot when we're talking about walking, but that's not something that we're going to get into for our class. Circumduction is making a circle. And so this is really a combination of flexion, extension, abduction, and adduction, just depending where you are in that circle. And so we think about that as your arm circles, our hips can do it, our thumbs can do it. So making a circle. Okay, a couple of these are really only go with one joint, and that's why we haven't mentioned them quite yet. So elevation and depression, showing us with our shoulder blade, our scapula here. So elevation, shrugging up, depression, pinching down. Think about kind of perfect posture. And so we could also say opening, closing the mouth, our jaw is elevation and depression. protraction and retraction. So if you watch his jaw again, the mandible, protraction is going anterior, retraction is going back from protraction, or depending on the joint, sometimes we can retract that jaw even farther behind our teeth line. For the scapula, you can kind of think of rounding your shoulders and pushing your shoulder blades anteriorly. That would be protraction. Or if you really pinch them back and think about perfect posture, that's retraction of the scapulae. And here's a nice summary to show you a lot of the other ones. The last two we haven't talked about yet are down here. So opposition, reposition. If you go thumb towards your pinky, that's opposition, opposite sides of the hand. And then if you go back over, so that's reposition, returning. This last one, I know there's not words here, but it shows inversion. So the ankle going in towards the other side, and eversion of the ankle. So towards the big toe, the medial side, towards the pinky, the lateral side. Inversion, eversion. And here's a nice chart you guys can use just to help you guys stay organized. So this is definitely a good thing to look at as you're studying. I'll see you in chapter 9.